Hey, everybody, welcome to Tea Talk. So it's April 23rd, and we have a topic set for tonight, and then we have also open Tea Talk. So, as usual, I want to make sure that I have time for open Tea Talk so that you have a chance to ask your questions and get some answers. So, it's some free consulting for you. If you are viewing after the fact, so after the live on our YouTube channel, you'll be able to go to our so it's Stalking Horse LLC, it's YouTube. Then you'll go to the little live section and you can see all of our Tea Talks. So if you view this after the fact, just to make sure that you send us an email to ttalk@stalkinghorse.llc.com if you have a question or a topic that you'd like to hear us talk about. So we know this is kind of odd for us to be just kind of doing this work for free, but it's our way of giving back, and we hope for a lot of participation so we can keep the channel going. Right now, we are streaming live on YouTube, Facebook, and LinkedIn. Eventually, we may pull back from that just depending on where the viewership is coming from. Personally, I like the YouTube view the best. I don't know. I just think it's like the nicest experience when you're on there, especially if you're home. You can put it on your TV, watch it, and then go on your phone so that you can make comments or ask questions in the comments from YouTube. So it's nice that way. I think it's a little different with Facebook and LinkedIn, because you can't, at least to my knowledge, there's no app on like the TV now. I guess you could like maybe cast it from your phone. I'm not really sure, but definitely YouTube is nice. So it looks like we've got some people who've joined, and we've got some from Vegas again and New York. So welcome back, Ricky. Nice to see you. I think you may have missed last week's. Hopefully you got to watch the recording on YouTube. So we're glad to see you back. And we also have Morgan from New York. Hello. Nice to see you here. I know you guys have had a crazy season. It was like winter and then summer and then winter again. And so I'm sure you've had a lot of fun with that, getting sick and whatnot. And then we also have Lainey back in from Florida. It's nice to see you guys. Just a reminder too, if you're in here from LinkedIn, please let me know by just making a comment. I can see your comments, but I can't respond to you in the actual comment, like in the app. So I'd have to respond to you, obviously talking to you from StreamYard, but I can't comment there. And I can't also see if you are on LinkedIn. You have to actually tell me. So it only tells me who's on from YouTube and I think Facebook also. So just let us know. Let's see. So again, reminder, shoot us an email at ttalk@stalkinghorse.llc.com for questions and future topics. And so let's see. Tonight, I actually also have some screen sharing to do. So fingers crossed that technology works with us and not against us. I know the first Tea Talk that we did, it was a little crazy with trying to screen share and everything. It's gotten quite a bit better, and we've been working with this platform for a little longer now. So I'm getting a little bit better at it. So we'll see how that goes. So just to get started here, I don't know how many of you know about Incident 2 and what it is. This is a topic that we decided to come out with because we see a lot of issues with it during audits. And we get a lot of requests for audits to be provided for practices regarding this topic because they get dinged from an insurance carrier for either using it when they're not supposed to or not having the documentation to support it. So we wanted to try to shed some light on it. And it seems to be one of those topics that's super confusing for providers. And I think that's because they use the term incident to in a lot of ways that it really kind of shouldn't be, but it is sort of a broad term, and it is a little bit confusing, to be honest. So let's see if we can talk through this. And as always, please feel free to share your comments or ask any questions that you may have. So first, I'm just going to start out by doing what I do best, which is yapping and just kind of like telling you a little bit about it in my own words, and then I'll jump into screen share to show you some items from CMS, and then I also have a document from Blue Cross Blue Shield. So incident to is really, it's technically a Medicare term. So it's terminology used by Medicare that became so popular that it's just kind of used now universally, and some carriers also have used it to describe the way certain services are provided. But it did start off with Medicare defining it. And I'll give you an example, a general example of what it is. So if you go to the doctor and let's say you need a shot, so you might need a flu shot, you might need a shot with an antibiotic because you're sick. But when you're there, the doctor lets you know, oh, hey, okay, we're going to go ahead and give you that injection today. And then usually the way that it works is the doctor leaves and then someone else comes in to give you the shot. Usually it's a medical assistant. Sometimes it might be a nurse. But they come in and they give you the shot, right? The doctor did not give you the shot. Not usually. Sometimes they do. But if it's just a regular old like flu shot or something, typically speaking, it's someone other than the doctor. And it's usually someone that does not bill you for a service. So in other words, you never get a bill from a medical assistant, right, at the doctor's office, but you do get a bill from the doctor, and your bill would include the services that you received that day. So they may have billed you for an office visit, and then they would also bill you for that injection that you were given. So even though the doctor or the nurse practitioner or PA, whatever, did not give you that injection in this example, it still would be billed under them as a service provided by them, technically speaking. So that is the whole incident to concept. It's where, personnel that's employed by the practice can perform a service and it can be billable under the physician. Now, the key there is, well, physician or provider. So I say that because in the example that I just used, it could also be true that you go in and you see the nurse practitioner, and the nurse practitioner says, hey, you need your flu shot. Medical assistant comes in, gives you the flu shot. The same applies there. And so the whole reason is that under that provider's licensure and stuff like that, they're able to provide that service, and then the medical assistant works directly for them, and then so it's able to be billed under that higher level provider. Now there are limits to this, right? So you're not going to go in and the doctor say, oh, you have a skin lesion there that needs to be removed, so we got to do a little minor surgery here today. And then the doctor doesn't leave, and then the medical assistant come in and perform the whole procedure, right? So that would not be acceptable. So there are limits to it, understandably so, right? We can't have, uneducated people that are in the office or like with a certain education level to provide like injections, performing surgeries, right? So we can't have that, patient safety and whatnot. So there are limitations to it. All has to do with scope of practice, and it does get pretty technical. Now, the most popular incident to issue, I'll say issue, or usage, maybe better, is when a practice has a MD or MDs and DOs, and then also has nurse practitioners, physician's assistants. And from Medicare, doctors get paid a certain amount. They have a fee schedule. It's called the physician's fee schedule, right? So they get paid a certain amount for a specific service or code. So for their office visits, they'll get paid a certain amount depending on the level of visit. Now, nurse practitioners and physician's assistants also get credentialed and whatnot through Medicare, and they can also bill Medicare directly. However, their fee schedule, so their payment, is about 15% less than that of an MD, right? So that's because the education level is different. So the pay scale is different. And so what happens with Incident 2 is many times these practices will use Incident 2 to bill for the service, so the visit that, let's say, a nurse practitioner provided, but it will be billed under the doctor's name. So that allows them to collect 100% of that fee schedule when a mid-level provider, like a nurse practitioner or PA, actually performed the service. So it is allowed, however, there are rules to follow, and there's documentation that needs to be there. And so again, this typically gets practices in some trouble because they usually start doing this and don't understand all of the rules behind it and what needs to be included in their documentation. And then in addition to that, they take this Medicare concept and these Medicare rules and they apply it to all of the insurances that they participate with. When again, I mentioned that this is really a Medicare concept. So every payer that you have needs to be looked at separately as to what their policies are. And their policies can even differ for the different plan types. So for example, there could be an insurance company that says, well, for our commercial insured patients, we do not allow any of that type of billing. But if you're billing for a Medicare Advantage patient, this is what we allow. So there can even be differences in the carrier, the payer's plan types on what the rules are. So it's super important that you understand that the administrators of the practice understand that, and the workflow is developed to safeguard you against erroneous reporting or making that kind of mistakes. You would be surprised at how crippling it can be to have a negative finding on an audit like that, because most people think that the big punishments come from these governmental payers like Medicare, Medicaid, which is true. Like that's where we see a lot of people like going to jail and whatnot. But if your practice is primarily made up of, let's say, Blue Cross patients, and then Blue Cross does an audit and they see that, you know, these claims were billed incorrectly, they can ask for tons of money back. And then that's how practices can become completely crippled and maybe go under, because they're going to take back all of that money. And obviously they can't run on nothing. So it's definitely a huge, huge problem. I'm going to go ahead and share my screen now and take a couple sips. I forgot. See, I didn't share with you guys what I was drinking. So this is my Starbucks cup, and it's one of those home cups, but there is Starbucks coffee in it. I just really like Starbucks coffee taste. So this was made in the Keurig, but with the Starbucks pod. supposed to be tea time, but I was feeling a little bit sleepy. I had a long day, long night Sunday, a long day yesterday. So anyway, this is some Starbucks coffee. Yeah, no tea. No tea tonight. Sorry, Ricky, no tea. I think you're into you're definitely into tea. So next time you'll have to share with us, or if you want to share now, what kind of tea you like the best. Oh, I need an oolong. I hate oolong tea. you, you know I hate oolong tea. We've had that conversation before. I can't stand it. I do like jasmine though. I like jasmine tea. No oolong tea. Okay, let me get back on task here. So I'm gonna go ahead and try to share a screen here. Wow, successful. Let me try to make your view a little bit bigger. I am like clapping for myself, I guess on the outside too, but on the inside, big time. Okay. So this document, oh, by the way, I had an issue with trying to get this information up on the YouTube community side. They've changed some of their settings. And so before I was putting like, Tea Talk materials for that, episode, I was putting the links there, but on YouTube, it did not want to accept it. And then they changed the way, like because they always wanted a picture, which I hate doing pictures for you guys with this information because you can't click on the link. It just doesn't make any sense. So the picture size too, they changed like what they want in there. So I went ahead and I put these documents on our website. So if you go to our website, which is www.stalkinghorsellc.com, I just had to add the www, right? So if you go onto there, you'll go under the Tea Talk area. So it's like you'll see Tea Talk, then you click on Tea Talk, and then you'll see the different episodes. And this one will have there will be a document in there for this, and it has all the links. So the items I'm going to share with you, you'll have the links to access these documents too. So the first one here is from CMS, just talking about Incident to services and supplies. So this is literally saying exactly what I was talking about, that Incident to services and supplies are those provided as a part of the physician's service, and that we've got, let's see, physicians, nurse practitioners, certified midwives, clinical nurse specialists, and physician's assistants. Our non-physician practitioners who are authorized to have services provided by auxiliary personnel. So again, like the example that I gave, if I go into the doctor's office, whether I see the nurse practitioner, the PA, or the doctor there, if I'm going to get like an injection, right, it's going to be most likely a medical assistant or an RN that's going to give me the injection, but the bill is going to go out under whoever like saw me that day, or the doctor or the MD. So that's just explaining the concept as a whole of really just what it is. I'm going to scroll down here for a second. I know sometimes it takes a second to load, so I'm going to be quiet. Okay. So here's some more information on it. So it does require direct supervision, generally speaking, and I'll tell you what I mean. That's in the next bullet here. So that means that the physician, like whoever it's being billed under, so it's a physician or nurse practitioner, whoever, they need to be available physically in the suite during the time that that service is being rendered. So suppose I'm going to come up with something crazy, but suppose they go to give me the flu shot and some terrible thing happens, like, I don't know, a reaction, right? An allergic reaction. I'm like having some anaphylactic reaction. So they have to be able to grab that higher level provider and say, hey, you know, there's an emergency going on here. I need you in here. And they need to be available, physically available, to go in and handle that situation, and assist. So this is a big problem area because sometimes we see where a practice will be billing for a service incident to, but the providers are all like gone on vacation. So how are you performing those services when there's no one present that's at a higher level that can oversee and supervise directly that service? So that's one area where we see a big problem. We'll dig into that a little bit more. Now, again, I said, generally speaking, this is the case, but there are some services like transitional care management, chronic care management, and then even some behavioral health services that only require general supervision. So that's a different definition. So it's not that it's not on site, like in the suite. That's if they don't require that. So that's a different requirement. So in case we have somebody in here who's like, wait a minute, I do chronic care management or transitional. But if you think of the nature of those services, it really explains, it makes common sense as to why they don't require direct supervision, because chronic care management, transitional care management, and behavioral health is mostly talking to the patient. It's not necessarily anything physical, really anything physical. So the requirement really doesn't need to be there for that. Okay, we're going to go on to the next one. Guys, just remember, if you have a question, go ahead and post in the comments. Oh, I see. So Ricky likes Iron Goddess Oolong. I don't even know what that is. That's some really fancy tea, isn't it? I like this little emoji thing here. That's really cute. Okay, so actually let me see if I can make this any like bigger. 1 second. Ah, that helps my struggling eyes, my aging eyes. Okay, so this is also technically from a part of Medicare. So this is from First Coast Service Options. It's Medicare. Oh, no, I'm sorry. This is actually from Novitas, I believe, which is a Medicare administrative contractor. If you don't know what that is, let me know, and maybe we'll do another tea talk to talk about what those are. Trying to change the view here for a second so that I can I may have to take my picture down in a minute so you can see the whole thing. So this goes into more detail about those office visits that I mentioned, because that's, again, the main culprit of the pain for practices is when they're doing those office visits with patients. And so I'm just going to highlight some of the items here. And so again, if you guys have questions, let me know. But this says physicians may bill evaluation and management services when furnished by a non-physician practitioner incident to his or her professional service. The physician may bill the CPT code that describes the evaluation and management service furnished. So again, that's exactly what we were saying. Like if I go in to my doctor's office and I see the nurse practitioner instead of the MD, and the nurse practitioner sees me for my I don't know, my cold that I have, or my allergies, the bill could possibly go out under the MD. So that would be incident 2. So they would be able to get full payment of the physician's fee schedule amount. So 100% of that amount under the physician side, even though a nurse practitioner saw me. So we are talking about only in the office as well. Let me make that clear here too, because I didn't mention before. But in the hospital setting, so physician rounds in the hospital, that's called split shared services. That's a completely different animal. It's a different talk. So this incident 2 only applies to the office setting. It does not apply to the hospital. So also, services provided by employees as incident 2 are covered when they meet all the requirements for incident 2 and are medically necessary for the individual needs of the patient. Obviously, they never want to cover anything that's not medically necessary. I know patients even get information sent to them about medical necessity on if a provider like requests an authorization or something. So they go on to talk about the requirements for a service to be covered as incident 2 for the physician service. The one that I highlighted was regarding the direct supervision, because again, we see that being a problem a lot. And per CMS, direct supervision is in the office setting does not mean that the physician must be present in the same room with his or her aide, but the physician must be present in the office suite and immediately available to provide assistance and direction throughout the time the aide is performing the services. So again, they need to be available. So they also talk about requirements for the provider and continued participation and active management of the patient's care. So because they're allowing payment under the physician's fee schedule, which again is about 15% higher, they are expecting the provider, the physician, the MD, to continue being an active participant in the care of that patient. So there needs to be information on an initial service being provided by the MD and also subsequent services that show that they are staying active in the course of their treatment and checking in on the patient for whatever that problem or condition is. And we'll talk more about that in a second too. So this document is really nice because it goes on to break up different sections and requirements. So the first section says qualifying as incident 2. And I highlighted this note. It says incident 2 billing does not apply to new patient or new problem for an established patient. So let me explain that. One of the number one things that we look for, aside from obviously that direct supervision, is if the physician, the MD, actually has developed a plan of care and a relationship with the patient regarding the condition that they're being seen for by the mid-level provider. So this is important because, again, it shows the providers, the MD's active participation and management for the patient. So let's take an example where a patient has, let's say, COPD, and they come in and they're a new patient. They see the physician. The physician may, get a history for the first time, go through what's going on with the patient, possibly prescribe some medications, but they're going to come up with a treatment plan. And that plan that's developed during that visit is super important. They may see them again for a follow-up and again develop a plan for that COPD, like based on maybe whatever testing that they had completed. But when they start seeing a mid-level provider, let's say in this case for COPD, so again, it can't be a new problem. So let's say the patient comes in, they have no new complaints. They feel good. They're just there to check in, get some medication refills, following up for their COPD. We need to know that there was an initial visit by an MD and that there is a plan in place that the mid-level provider is going to continue to follow. They have to go basically off doctor's orders, right? So the plan is what the doctor is saying needs to happen for this patient. So as long as they're using that plan and following it, but they do need to document also in their own words, then they're typically good to go. They've got direct supervision and they're continuing to follow that plan. There's no new complaints. However, they need to show that in documentation, and it gets really challenging in these kinds of audits because a lot of times that information isn't there, but they do allow for almost like that plan to be shown in the current note. So previous information to be shown in there as a reference. And I love that. I highly recommend it because it's just going to protect your practice. It's going to protect you as a, either the owner of the practice, going to protect the MD to show, yeah, this patient was seen on this date. This was the plan that was, put in place by Dr. whatever Smith. And, this is the continue the same plan, continue this medication, et cetera, whatever they put in there. Right. But you're going to be able to show right there in that documentation. Otherwise you have to like hunt backwards. And then if you're audited, you have to provide that information. Like Medicare is not going to go hunting through your EMR and say, oh, let me help you pass this audit. They're going to say, you send us the support for this. You have to prove, the burden is on you to prove that you've done this appropriately. So then you have to hope that your staff can go back and find out, okay, where's that plan? Okay, this is where they saw the MD. Here's that plan that's being used. And this is going to support, this note, and it's going to show the participation by the MD. That's very time consuming and it's very burdensome. And also, if you hire an external company, like such as ours, to do an audit for that, it can get costly because if you expect that auditing firm to dig through your EMR to find the proof for that, that's going to take time. I definitely wouldn't recommend that you do that. I highly recommend that you have a section in that note where that last visit from the MD with that plan can be pulled in and clearly noted like what it's from so that it's clear. But that will squash a lot of those questions about, oh, well, when's the last time they saw the MD? How do we know that they're participating? And well, what was their plan? Is this something different? Is this something new? So then the proof is right there. Then the other part of that, of course, is making sure that you can show that the MD is there's direct supervision. Many go ahead and create a what do you call it? Like a macro or something in the software to like put in there so that it shows that the MD was physically present in the suite during the time of the service. Of course, you have to make sure that there was someone. It doesn't have to be the MD who saw the patient last and created that plan. So that's odd, right? When you think of it in one way, you're thinking, oh, well, it's got to be that same provider. But technically it does not, because the whole idea is, again, like if a higher level decision needs to be made, that somebody with that higher level education is available to step in, that they're directly available to come in if needed. So that's where that comes from. It doesn't necessarily have to be the same MD doing the direct supervision, but it does have to be someone of that higher level credential, right? So hopefully that makes sense to you guys. So yeah, making sure that that plan is in there is like, oh gosh, super helpful in an audit situation. And so we kind of did touch on that active participation right here. But it is important to note too that they are expected to perform subsequent services as well. Like the patient can't just be seeing the mid-level provider for years, the same thing happening, and that be okay. So many practices develop a policy that if there's incident 2 going on, that they must be seen by an MD after X number of visits or X number of months. But some patients, don't necessarily come in that often, maybe twice a year. So it's important though to get some kind of plan and some kind of policy set so that something like that doesn't slip through the cracks, because you do also need to be able to show that they're continuing participation in some way, because again, you're getting paid for that higher level of service of education. So they did actually make a good note on that, which I really liked. So they stated, a patient with chronic sinusitis will probably not have to be seen by the physician as often as a patient with congestive heart failure. So super true, right? So chronic sinusitis, obviously awful to have, very annoying, can flare up here and there, just very obnoxious condition. So don't want to like downplay that. But congestive heart failure is obviously a more severe condition as far as threat to life. So we could see how we would expect the physician to see the patient with congestive heart failure more often as far as showing that interaction in their care than we would if it was chronic sinusitis. So I think that just makes sense. So they actually also came up with a section for non-covered incident too. So I thought that this was good to take a look at. I'm not going to really like dig into this. I haven't seen anyone ask anything directly about it. But yes, it is pretty complex. So Ricky, you're like a number one contributor tonight. So thank you for the comments. Yeah, it is pretty complex. That's, I think, where, again, a lot of that confusion comes from. And so it's not typically that a practice is intentionally doing something wrong. It's just that this gets confusing. And again, so far, what we're going over is super specific to Medicare. So we haven't even talked yet about other carriers, other payers. So let's keep it moving here. So this is what they say about the documentation, and this is oftentimes missed and reason for failing the audits. So even if you're doing it right, doesn't matter if you don't document it, right? Because as they say, if it wasn't documented, it wasn't done. So of course, we need to know the individual who rendered the service. That sounds like common sense, but you'd be surprised. So it's actually not common sense, because I'll tell you an experience that we had. We were taking on a new client for revenue cycle management services. And so we were looking at their documentation, applying codes and performing billing. And we noticed that there was two providers on there all the time. And so the signatures were on there, two providers. And so it looked like maybe it was incident 2, but then it's like, well, I mean, which one actually rendered the service? Which one was supervising? Then okay, once we figured that out, okay, who was the direct supervision under for that day? Okay, and then all right, after that, well, who is actually like face to face? Did the other provider have face to face? Because sometimes practices will tell you that they're doing something incident 2, but the physician actually sees the patient in addition to the nurse practitioner. They do that a lot when they're in training, which is something completely different. So that's not incident 2. That's this the physician actually saw them, rendered the full face-to-face. It's just that they did it together because they're in training. So that's a different situation. And then you don't want to necessarily have to look for all of those other components to make sure that you're good to go for the incident 2. So who rendered the service needs to be clear. And then again, that physician's presence in the office at the time of the service. So if we've had this happen before too, where we found out there's a single physician practice, and then there was mid-level practitioners. Come to find out, the physician had gone on vacation for 2 weeks, but the mid-level practitioners were continuing to see patients. Um, and there was sign off that was performed after the fact from both providers. And so it was impossible to know just based off of looking at the record that that physician was actually on vacation. So those services did not qualify as incident to because direct supervision was not available by any higher level practitioner. So there was no MD there that was available in the suite. So those needed to be billed under the mid-level practitioner. So we ended up having to go back and do some corrected claims to get those paid correctly under the mid-levels payment rate instead of the MD because that was not appropriate. But again, if you don't know if they're actually physically present in the suite, that's problematic. Or if there's just a macro that's there and it's pressed every time, that's also not good. Because trust me, when they go dig in to find out if that criteria is met, they dig hard. So they will find your social photos of you in, Cancun or Italy or Spain or whatever, and they will be like, "How are you providing direct supervision while, being while in Spain? Like you can't, right?" So they figured that stuff out pretty quickly too. And so then also the physician's initiation and continued involvement in the treatment. So we kind of talked about that a lot, like making sure that that initial plan is there and that you're pulling in the information into the current note is highly recommended. Um, Now this last one I highlighted in like this like lime green color. As I have a story about it. So it says services within the scope of practice of the non-physician practitioner as defined by state law. So this one gives me heartburn because a while back we started working with a practice that had behavioral health services, and we work with behavioral health services a lot. But this particular practice was set up in an interesting way, and there was um, services where a patient, the way when you read the note, when you read the documentation, it was like the patient had therapy services by like a licensed clinical social worker, right? So that was all there and documented well, like very, very well. But then there was separate documentation with a separate time component, because if you know behavioral health coding, like there's time element to the therapy, right? So the E&M was well documented separate from that. So there's an evaluation and management service done separately, and the patient's conditions were discussed, and then like continuation of their medications that was mentioned and everything. So like full E&M, and then there was a physician's signature as well as a therapist signature. So it appeared as though the patient had come in and seen a therapist or a social worker, right, for the therapy, and then also saw an MD or a nurse practitioner for the medication management. So under incident 2, didn't really seem to be a question of, oh yeah, you can bill that under the higher level provider. So you can bill it under the nurse practitioner or the MD completely because of the rules of incident 2. Well, come to find out, that wasn't really what was happening. The social worker was trained to document in this specific way, this method. And if they didn't feel that the patient needed anything done, like they were stable, this was just language that was in the note. And then all the notes were just signed off by the higher level providers because they reviewed the documentation. So it was completely misleading. So then it came down to, okay, well, they're following the plan that was established and everything. So what does the state law say about licensed clinical social workers? So the state that they were in, we investigated that, And it was very bizarre because the state law appeared to support them as a licensed clinical social worker performing evaluation and management services based on the limited definition that was in there under the state law. So then we had to push it to Medicare. We had to contact their Medicare administrative contractor, so their local Medicare administrator, and we had to actually submit the question to them. And it took quite a bit of back and forth because we sent them the state law and everything. Long story short, it came back that no, they are not allowed to do that, that Medicare doesn't recognize that credential, so the licensed clinical social workers, as being able to perform that service, even though the state law, the way that it read, it appeared that it was in their scope of practice. So that was a bizarre situation. So when I read that, I'm like, oh, you really are going to want to check with your MAC. But as far as I've been able to tell since then, the answer has been no everywhere. So I just think that in the state law, it's not well written. The way they explain that scope of practice for the licensed clinical social worker is not very good. So that would be a big fat no for Medicare. But that was an interesting, very, very interesting case. But then, we, had to work on cleanup from that. So very, very interesting though. Let's see here. What else do I have? The next couple pages, you guys, may want to take a look at. It goes to like specific billing information for it, but I'm not going to touch on that tonight. Otherwise, we'll be here until midnight. So the last piece of the puzzle from Incident 2 is I mentioned that this is really Medicare like term, right? But that other payers are starting to talk about it. So I wanted to give you guys an example of what I was talking about, that just because Medicare says this doesn't mean that your other payers are okay with it. That is not at all what it means. And not everyone is not required to follow whatever Medicare says. Many providers have that as a misunderstanding. A lot of the physicians and nurse practitioners and PAs think, well, if Medicare said it, that's the way that it is. That's not true. That's why you have all these individual contracts with these other carriers. So that can be defined by the individual contracts. So what you're allowed to do under that contract. So this shows Blue Cross of Louisiana. This is available online. So again, you'll have, if you go to our website and you go to T-Talk on our website, you'll be able to look for today's date, T-Talk. If you click on it, it'll show you a PDF and you can get the links to all the information that I've shared tonight with you. So you'll be able to see this there. So what Blue Cross says is that if network participation is available for a provider type, then that provider type is required to file claims under their own provider number. Let me make this a little bit bigger. So they go on to say that provider types that are required to file claims under their own provider number include, but may not be limited to, nurse practitioner, physician's assistant, dietitian, so on and so forth. So they're literally saying here that you're able to get a contract with them as a nurse practitioner and a physician's assistant and the others that are listed. Therefore, you must bill under your own credential. So whatever their payment rate is for that provider type is what you'll get. There's none of this Incident 2 where you can bill under the MD if they're supervising, and it does not work like that. They do not care. If you furnish the service, it goes under you. Then you have a lot of places that will say, well, while they're getting credentialed and working on a contract, maybe, then we can go ahead and bill them under the doctor. No, if they're going through training, then they should be with the physician. And again, if the physician is the MD is the one seeing the patient and furnishing the service, then that needs to be clear. And then that's not what incident 2 is, right? So we just need to make sure that we're actually understanding what's going on. And that is through clear documentation. So again, that second PDF that I shared that you'll have the link to, that's really key with that documentation piece. Oh, look. Hi, Kimberly. I haven't seen you or heard from you in a bit. Thank you so much for joining. It's nice to see you in here. Looks like you're on Facebook. I hope that the view is nice through Facebook. Thanks for joining. So hopefully this gives you a good glimpse into the world of Incident 2 and explain some of the challenges with the providers. Again, it's not a straightforward concept. Like it surely is difficult when you're first getting to understand it. But this is one of the first things I ask, like about audits, or if somebody's asking for billing services from us, billing or coding services from us, it's like, okay, do you do Incident 2? So we need to know that. We need to get that workflow in line and understand what's going on and make sure all those elements are there before we get into it. So as I expected, going through this took about a full hour, but I'm still able to hang around. If you guys have any questions, again, feel free to ask in the comment. And then again, don't forget, you can email us at ttalk@stalkinghorseLLC.com. And you can say, hey, I have this topic. I want to hear about chronic care management, or I want to hear about, I want to hear about cabbage coding, or whatever it may be. You can ask, like, hey, this is the topic that I'd like you guys to talk about. Or if you have a specific question, if you have an example of like a snip of documentation, of course, no PHI in it, but just, hey, in this scenario, what do you think, or what would you do? We'll certainly answer those. So go ahead and send us over any of your requests or your questions, and we'll get them on the T-Talk. So it looks like, okay, we have a question. This is hysterical. What is cabbage coding? So it's it's not the vegetable. It's actually CABG, all capitals. So it's coronary bypass surgery coding. So for people who end up with really clogged up arteries in their heart, they may need surgery to bypass some of the arteries. So it's bypass surgery, right? So they'll bypass the arteries to get the blood flow into the heart so that they don't have a heart attack. So that's cabbage coding, but it's actually, once you get it down, it's pretty smooth sailing. Like it's pretty good. It is a little bit challenging at first. Hi, Tina. Thank you so much. I didn't see that you had joined tonight. Thank you. I appreciate it. I'm glad that you found it informative. And don't forget to, you guys can message us with any questions. I know your team. I think a couple have kind of jumped on. So yeah, anything you guys need, just let us know. Appreciate it. And no need to say sorry. It just made me laugh because I just thought of we had just passed St. Patrick's Day, so I just thought of cabbage, like literal cabbage. And I always used to think that too. I'm like, why cabbage? But I mean, it's obviously just the acronym, but it is pretty funny. So you get the star award for making me laugh. I couldn't hold it in. That was cute. Thank you. But when I was first getting into cardiology and then vascular surgery as well is just another animal. Yes, corned beef and cabbage. I actually made it this year. I made some corned beef and cabbage. Years previous, I used to go over to brother-in-law's house, and they were busy this year, something else. So I had to try to make it myself. I did it. I did pretty good for the first time. So yeah, I was pretty proud of myself. It was really good too. Okay, guys. Well, thank you so much for joining. I appreciate it. Don't forget to reach out with any questions for next time. I think next week, I don't know. I'm kind of debating between a couple of topics unless something comes in through by request. So we'll see. We'll see. We'll see what we come up with and what comes in. We try to wait a little bit to give people time to send us an email if they have a request before finalizing what the talk will be on. But thank you guys so much for joining tonight. We really appreciate it. And we will see you again next Tuesday for Tea Talk. And don't forget to bring your tea. And hopefully next week I'll get tea instead of coffee. All right. Thanks. Have a good night.